like to talk and stuff.
Question.
But you see questions, just let me know, and I'm happy to take questions at any point during this.
Katie, I'll keep an eye out too, since you're kind of running things.
Awesome. Thanks,
Thank
Zoe.
you.
All right. Well, guys, thank you for coming out tonight. My name is Katie Stevens. I'm the president of the Clinical Ross Emergency Medicine Interest Group. We thank you guys for coming out. I know it's kind of late for some of us, but we're really excited to have Dr. Brian Kendall here with us tonight and giving us a lecture on chest pain and how to assess in the emergency department. Dr. Kendall, take it away.
Thanks, Katie. Thank you all very much for having me and allowing me to do this. This is feels very full circle. I am a Ross alum, graduated in 2013, and currently the clerkship director at Texas Tech Health Science Center in Lubbock, Texas. And I'm happy to do this and hopefully get to do some more in the future. So tonight we're going to talk about chest pain. I know that we have a mix of students on the call today. But I think chest pain is one of those that if you're interested in emergency medicine, this is going to be something that you see on every single shift. There will never be a shift that you go that you don't have at least one person that has chest pain or some form of chest pain. And so I like to start off my lecture series with this lecture, mainly because I think it's very easy to kind of break it down and go through different elements of our history and our physical exam and the types of labs and imaging and all that kind of stuff that we're going to be ordering and looking at. So I feel like it gives us a good foundation for other chief complaints that we deal with in the emergency department. Let me see. There we go. So our objectives tonight are going to be to describe the typical approach to chest pain, which again is the most common chief complaint in the emergency department. Review important aspects of the history and physical exam in patients with chest pain. We're going to list the life-threatening causes of chest pain and how each one is diagnosed and treated. We're going to demonstrate the process of reading a normal EKG and chest x-ray and how to recognize abnormal findings. And then my goal is really to prepare all students, but for this lecture specifically, it's geared more towards those fourth-year medical students who are, pretty much set on being in the emergency department and giving you a foundation of, as you go forward in your career, whether that's intern year of residency or, your first year out as an attending, something that you can come back to and say, okay, yes, these are the fundamentals of chest pain and how I'm assessing a patient in the emergency department. So I'd like to start off by introducing you to our patient. We have a 54-year-old male. They come in with a chief complaint of chest pain. Vital signs are as follows. Heart rate is 50 beats per minute, a respiratory rate of 16. They have a blood pressure of 120/80. They're saturating at 100% on room air, and their temperature is 98.6. We can tell a lot about this patient just from this one slide. And I can tell you in my mind already, my wheels are turning, and I've got my differential diagnosis kind of in my head, lining up 1 through, whatever it might be, 10 or, 15, whatever, kind of, I'm going through my head of all the things that this could possibly be. Is there anybody out there that would want to tell me, is there an abnormal vital sign here and something that you would be maybe concerned about?
The heart rate?
Yeah, the heart rate, fast or slow?
Slow.
Slow. What does that make you think of? Does that make you think of anything in particular? There's no wrong answer. Makes me think of a couple. I'm sorry?
I don't have anything right now. I'm sorry.
Okay, that's okay. So it makes me think of a couple of things. Anybody else want to take a crack at it? What does bradycardia make you think of?
Heart block.
Okay, heart block, good. Very good. Anything else? Great. So heart block is a great one, right? If we're talking about a complete heart block or third degree heart block, then the ventricular pace or rhythm will take over, and that's usually slow. It's usually going to be bradycardic. So I would definitely want to make sure that this patient doesn't have a complete heart block. Other things I think about every once in a while in ACS or acute coronary syndrome, you will see patients who are bradycardic. That, you know, it's a little counterintuitive. A lot of times you think, oh, they're going to be stressed, they're in so much pain, their heart rate's going to be fast. But especially in patients that have NSTEMIs, we'll see a lot of bradycardia. And that's kind of one of those first, anytime I see a patient that's bradycardic, that's immediately where my mind goes is, you know, could this be an acute coronary syndrome or NSTEMI, STEMI, unstable angina, you know, any of those things. There's also things that I look at this and I think, okay, it's probably not this problem or with the rest of these vitals, right? The rest of the vitals are normal. Is there anything that this reassures you and says, oh, it's probably not this diagnosis when we're talking about chest pain?
Probably not like a aneurysm, a thoracic aortic aneurysm, because the blood pressure is fine and he's
Great.
got a low heart rate. So
Yeah, exactly. That's fantastic. Yeah, so you have a normal blood pressure, so probably not like a dissection or a thoracic aortic aneurysm. I think that's fantastic. The other thing I think about is it's probably not a pulmonary embolism, right? Normally with PE, we've got at least some hypoxia, typically, maybe some tachycardia as well. So I can sit there and think, well, it's probably not a PE. So as you can see from just from this one slide and this basic information, we're already sorting out our differentials of, okay, what's more likely to be possible here and what's less likely to be possible. And then as I continue on with this patient encounter, I'm going to ask certain questions and perform certain things on my physical exam to help me continue to reorder my differential so that when I get to the point where I need to order labs, imaging, and therapeutics, I've got a good sense of what I'm actually treating. So the most important thing is, you know, in any patient encounter is the history. I'm sure everybody has heard that, like, what is it? 90% of the history or 90% of your diagnosis comes from the patient's history. Have y'all heard that before? Is Ross still preaching that? I think most medical schools do, and it's very true. I've gotten to the point in my career where the majority of patients, I've already diagnosed them just off what is on the vital signs and what's on the triage note from the nurse. I've already got an idea and a diagnosis in my head and what I'm going to be doing for this patient. So on that history, we want to make sure we do that OPQRST. Does everybody remember that in doing this? Does anybody remember what it stands for and what we're using it for?
For the
I
pain.
use like old carts, but it's like onset, pain, character, like alleviating factors, aggravating factors, timing, things like that.
Yes, exactly. Very nice. Yeah. So all those things about that you want to ask about the pain. When did your pain start? How long has it been going on for? Does it radiate? What's the quality of the pain? Is it sharp? Is it stabbing? Is it dull? Is it pressure? Any other associated symptoms that go along with that pain? You know, what have you tried taking for the pain? Does anything alleviate it? Does anything make it worse? Is it made worse with exertion or food? All of those questions become very important in our history because it allows us to characterize that pain and what this patient is feeling so that we can try our best to understand a little bit more what's going on. And then we would move on to our review of systems. This becomes important mainly because a lot of patients you'll encounter in the emergency department, most of them are solely focused on the one issue that brought them to the ER. And they'll forget details about, other things that may be going on. So, it's like, okay, so you're having chest pain. What other symptoms are you having? Are you having fever? Oh yeah, actually I did have a fever earlier this morning. I totally forgot about that. Are you having cough? Oh yeah, I was coughing earlier. So now all of a sudden, instead of thinking heart attack with our chest pain, we're going more down this path of maybe it's a pneumonia or something like that. So the review of systems becomes very important as well and kind of helping our patient to jog their memory. Past medical history becomes very important here. What are some specific things that you as the student will want to gain as far as knowledge on a patient's past medical history so that you can then tell your attending or your resident? What are some specific questions you want to ask about a patient's past medical history?
If they've had like a prior MI in the past or any type of cardiac event.
Good. Very good. What
Previous
else?
surgeries?
I'm sorry?
Previous surgeries? Or
Previous
hospitalizations?
Yeah, good. Previous surgeries, hospitalizations, good.
If they've ever had an episode like this before.
Good. Yeah, ever had an episode like this before? What are some risk factors for chest pain, specifically maybe ACS or acute coronary syndrome, that we need to ask about? Does this patient have a history of?
High blood pressure and cholesterol issues.
Good. Yeah. So high blood pressure, high cholesterol, diabetes, right? So those are three big ones, right? What about our social history? What's a big risk factor with social history when we're talking about ACS and chest pain?
Smoking.
Smoking, yes, we want to ask about smoking. We also want to ask about drug use in the social history as well, right? When somebody tell me, when you're talking to a patient about their drug use history, how are you asking that? How are you phrasing that question?
I just asked them if they have any illicit drug use in the past.
Okay. How many people nowadays consider marijuana to be illicit?
Yeah, like none of my patients say that. They always say I don't consider it a drug, and I'm like, well, they say no drugs, and I say, well,
Yeah.
what about marijuana? And they're like,
Oh, it's like,
yes
oh
or no.
yeah. Yeah.
So
Exactly. So with the past medical history and with the social history, I will encourage you to be instead of just asking a patient, hey, what past medical history do you have, right? A lot of patients don't quite understand that. So I've gotten into the habit of specifically asking them what I'm looking for. Do you have a history of diabetes? Do you have a history of high blood pressure? Do you have a history of high cholesterol? Do you have a history of coronary artery disease or previous heart attacks or strokes, right? Do you have a history of smoking? Have you ever smoked? When was the last time you smoked? Do you have a history of drinking? How often do you drink? Do you have a history of any type of drug use? Marijuana, heroin, cocaine, meth? What drugs do you use? And then specifically then, how do you use those drugs? If you use meth, how are you using it? Are you snorting it? Are you smoking it? Are you injecting it? Because all of those things make a huge difference, right? If somebody's smoking meth, that makes me worry about their lungs. Maybe they've now got a pneumonia or they've got, an early onset COPD or something like that. Whereas if they're injecting it, now all of a sudden I'm really worried about endocarditis, right? And this person is throwing little emboli into their lungs, leading to, this horrible kind of septic emboli type picture, right? So those are the type of things that I would encourage you to do, is not just ask, what's your medical history? What's your social history? Really get specific about what you want out of that. And you'll find that it's a lot more useful. And when you go talk to your attendings, they're going to be like, wow, that's great. You did a great job. Now, do I care about in a chest pain patient? Do I care about a past medical history of gout? No, I do not. Not as an ER physician. So leave that stuff out. Don't go telling your attendings on your chest pain patients, oh yeah, they've been dealing with gout for 20 years. Because your attendings going to immediately turn you off. They're not going to listen to you anymore because they've got enough stuff going on. They're like, okay, now I'm getting the entire history and physical and not a focused history and physical from my medical student. So family history becomes important. We'll talk about this in a little bit, but family history of any kind of heart issues, MIs, sudden cardiac death, that kind of stuff prior to the age of 50 or 55 becomes important. And then surgical history, as mentioned, becomes important too. And again, you have to ask them specifics. Have you ever had stents placed in your heart? Have you ever had a CABG before? Have you ever had any valves replaced? You have to be very specific with your patients. So you need to know what to ask so that you get the information that you need. Any questions on this slide before we continue on? Okay. I promise the rest of them will be quicker. I just think that this is truly important to be able to get. All right, so for the physical exam, I'm not going to be able to do this as well as we could if we were in person. But what are some important areas on the physical exam in a patient with chest pain that you would want to focus on?
If they have an
Cardiac exam.
apical impulse.
I'm sorry?
Go ahead, Lindsay.
I was just gonna say cardiac exam.
Cardiac exam, good. Yeah, very good. How many people feel like they're really good at listening to murmurs? Yeah, it's one of those things where the cardiac exam I think is evolving, especially as we get more and more technology. We all have stethoscopes, we all technically should know how to use them, but it's extremely hard in the emergency department to hear anything other than breath sounds and just a basic kind of heart exam. So I do like the using that and doing a cardiac exam, but I get a lot more interested in not just like heart sounds, but more pulses, right? So I'll always check the patient's pulse, and I'm feeling for things like, is it bounding? Is it thready? Is it regular or is it irregular? Do I have a different feeling pulse on one arm compared to the other one? Those are all kind of clues that we get, that I want you to be more attuned to when you're talking about a cardiac exam on a patient. I think pulse has become very important. You can definitely feel for things like the apical impulse, Katie. I think that's great too. But you'll notice, in the ER, when you're doing your rotations or you're in residency doing that, a lot of that kind of goes out the window because you're so busy. But I've found that just by while I'm sitting there talking to the patient, I literally just will have my hand on their pulse and just feel their pulse as they're talking to me. And that can tell you a lot of information too. It'll tell you about their perfusion status. It'll tell you if they're an AFib. It'll tell you if they're tachycardic or bradycardic. So and then you can also, you're feeling their skin at that time too. Is their skin diaphoretic? Are they really sweaty? Or is it, is it normal? So there are a lot of things that you can tell just by doing some simple things like that too. Anything else on the physical exam that we would want to focus on in a patient with chest pain?
Lung sounds?
Yeah, lung sounds. I think that's fantastic. The lung sounds I think are very easily listened to in the emergency department. And I think that you definitely can learn a lot from that, right? So if you have diminished breath sounds on one side, that'll make you think of something. If you hear rows or crackles, that'll help you to determine, oh, maybe it's something else going on. So definitely something good there too. Anything else that you would want to do in a chest pain patient?
Yeah,
All right.
I heard abdominal and then something else.
I was gonna say, like, look at the neck for any JVD or not.
Yeah, good. So looking at the neck, looking for JVD, looking for any kind of distended veins can give you a lot of clues. Abdominal exam, I think, is very smart to do. I can't tell you how many times I've seen residents kind of have a patient come in with chest pain. They don't do an abdominal exam. The patient's tachycardic and maybe they're mildly hypoxic. So the resident just goes immediately to do a CT for a pulmonary embolism. And on that CTPE, there's no pulmonary embolism, but they catch the very bottom part or very upper part of the abdomen, and that patient has acute cholecystitis. I've seen this more than once. So I think doing an abdominal exam in chest pain patients is fantastic. And then overall, just a general exam as well too, right? So, just the general appearance of the patient. Do they look pale? Do they look diaphoretic? Do they look like they're an extremis, like they're feeling like they're about to die? Right? Those are all big things that we worry about in the emergency department. If you see somebody like that, then those things like aortic dissection and all those type of things are now coming up to the top of my list here. All right. So with differential diagnosis, this is one of the biggest places where I see medical students get caught up. So on every other rotation that you do, surgery, peds, internal medicine, family medicine, psych, what you are expected to do is create a differential diagnosis with your most likely diagnosis being at the top. So you're using all of your information that you've gotten from your history and physical and making your differential diagnosis, right? That's not how we operate in the emergency department. I may come out of a room and sit there and say, this patient probably has costochondritis, a non-life-threatening inflammation of the ribs that will cause pain and whatever else. But that's not what I'm going to my attending and telling them. What I'm going to my attending and saying is, this is my patient, this is the history, this is what I found on my physical exam. On my differential, I have acute coronary syndrome, pneumonia, pulmonary embolus, right? I'm listing all of my life-threatening causes first that I think are more like the most likely ones of those life-threatening causes. And then I also can go, once I'm done with those, once I've told my attending those life-threatening ones that I'm really worried about, then I'll go on to say, and although my biggest thought is that this is probably benign cause of chest pain, like a costochondritis. Then I continue on saying, however, through my history and physical exam, I'm able to determine that it's not pneumonia because the patient doesn't have a fever and they don't, whatever. It's not a pulmonary embolism because the patient, or I don't think it's a pulmonary embolism because the patient has a normal heart rate and they have a normal pulse ox, but I can't completely rule out acute coronary syndrome with my history and physical exam. Therefore, the workup that I'm going to obtain is yada, 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 yada. Does that make sense to everybody? What we're trying to do is set the tone for our attending and for ourselves eventually in the future of our job in the emergency department is to get rid of all of the life-threatening issues that could possibly be harming this patient and then letting them go home and saying, I don't know what this is, but it's not, whatever it is, it's not killing you. You will survive the next 24 hours to go follow up with your primary care doctor and they can continue on in their workup of you. So that's your goal as an emergency medicine physician, ruling out all the life-threatening things so that the only things that you're left with are the non-life-threatening things, and then hopefully you can discharge that patient home. Or if you can't rule out all the life-threatening things, or you've diagnosed them with a life-threatening thing, then you admit them to the hospital and you get all the necessary consultants and whatever else on board to help continue that evaluation to figure out if it's life-threatening or not. On that topic, what are the life-threatening causes of chest pain? I've cheated a little bit and given you a few of them. Can anybody name the life-threatening causes?
STEMI.
I'm sorry?
A STEMI.
STEMI. Okay, so STEMI is under the umbrella of a broader term. I've said it a couple times.
Dissection, PE.
Okay, dissection, PE, those are two of the life-threatening causes, yes. Does anybody know the umbrella term that STEMI is under? It's along with STEMI, NSTEMI, and unstable angina are all underneath this.
Acute coronary syndrome.
Yes, ACS, acute coronary syndrome. So when you talk about acute coronary syndrome, what you're saying is it could be STEMI, NSTEMI, or unstable angina. Then we talk about myocardial infarction. Only two of these fall under the term myocardial infarction. What's that? Which two are those?
STEMI and STEMI.
STEMI and NSTEMI, yep. So you get rid of unstable angina. STEMI and NSTEMI fall under MI, or myocardial infarction. Unstable angina doesn't. So ACS covers all three. MI just covers the STEMI and NSTEMI. And then so when you say ACS, that's what everybody understands that to mean is STEMI, NSTEMI, and unstable angina. All right, so we have ACS, we have dissection, we have PE. What are the other ones?
Cardiac tamponade.
Good, cardiac tamponade, very good.
Can also have like pneumothorax.
Pneumothorax, fantastic. Specifically a tension pneumothorax. What else? What if I had chest pain and a fever?
Carditis.
I'm sorry?
Endocarditis, pericarditis.
Not necessarily endocarditis. That actually doesn't cause much pain. The sequelae of endocarditis
Pericarditis?
will. But if I have fever, cough, and chest pain,
Pericarditis.
pneumonia. So pericarditis actually isn't life-threatening in most cases. Again, pericarditis in and of itself will cause chest pain, but most people will survive it, no problem. The biggest risk with pericarditis is effusion. So you get that pericardial effusion, which then leads to tamponade. But pneumonia is on there too. And then there's one more that I'm thinking of that has nothing to do with the lungs or the heart. You heard of an esophageal rupture?
Yeah. Yeah.
Yeah. So esophageal rupture. So there's 7 deadly causes of chest pain. And this is one question that you'll get pimped on all the time while in the emergency department. If you have a patient with chest pain, your attending will ask you at some point or another, okay, what are the 7 deadly causes of chest pain, life-threatening causes of chest pain? So it's good to memorize that list. Okay. So we've seen our patient, we've seen the vitals, we've gotten our history from this patient, we have done our physical exam, and now we've come back to our attending, we're sitting there, we're talking about our differential diagnosis. And let's say that all of these things are on our differential diagnosis, and then our attending says, okay, so how are you going to work this up? What are you going to do to rule out acute coronary syndrome? What are you going to do to rule out pneumothorax? What are you going to do to rule out pneumonia? What are you going to do to rule out aortic dissection, pulmonary embolism, esophageal rupture, pericardial tamponade? So these are the things that you are going to do. And this is why you'll see on most chest pain patients, we get these specific things, right? So acute coronary syndrome, we need a troponin, right? So that's blood work. There are different types of troponin. This is kind of outside the scope of this lecture, but just be aware that there are different types, and where, depending on what hospital you are working at, you need to understand which type of troponin they are using. There's high sensitivity troponin, there's troponin I, troponin T. So you just need to make sure that you're using the troponin correctly and understanding what a normal value is there. For ACS, we're also going to get an EK. So troponin in and of itself will tell you if there's damage going on in the heart, potentially, right? So we will see elevated troponin then in which of the 3 things underneath acute coronary syndrome. Will you see an elevated troponin in a STEMI?
Yes.
Yes, you will, right? Because it's a myocardial infarction. There's infarction of the heart going on. The troponin will be released. So eventually you will see an increase or an elevation in the troponin. Initially, you may not. If the patient comes in 30 minutes after their chest pain started, you may have a normal troponin. Sometimes it can take a couple of hours for you to actually see elevated levels in the blood, but eventually you will have an elevated troponin. What about an in-STEMI? Will you see an elevated troponin in STEMI?
Yes.
Yeah, you will. Again, myocardial infarction, right? So you'll see elevated troponin in STEMI. Here's the tricky one. What about unstable angina? Will you see an elevated troponin in unstable angina?
No.
Exactly. And I don't like to say never, right? It's always a possibility, but usually you will have a normal troponin in unstable angina. Okay. What about an EKG? So we do need an EKG, right? Which one of those 3, or which 2 or 3, or which ones of those 3 will you see an abnormal EKG in? Will you see an abnormal EKG in a STEMI?
Yes.
Yes, you will, right? Because that's what's in the name, ST elevation myocardial infarction, right? So you will see ST elevations on the EKG. What about an in-STEMI? Will you be able to diagnose an in-STEMI based off of the EKG?
Well, since you said diagnose, well, at first I was inclined to say yes, you can see some possible ischemic changes, but then you said diagnose, which kind of threw my answer off. So it's kind of a yes and a no.
Very, very good. Yeah, no, you're exactly right. So not necessarily. You can have a completely normal EKG in an in-STEMI. It's very possible. Now, not always. You're exactly right. You can see some ischemic changes, but if you're seeing ST elevations, it immediately becomes, it's not an in-STEMI anymore. It's now a STEMI, right? And then what about unstable angina? Can you diagnose unstable angina based off of an EKG?
No.
No, exactly. The answer again is no, right? So then we come to the heart score. Has anybody ever heard of a heart score? And I can't see everybody. I wish I could. Has everybody heard of a heart score before? Okay. That's good because we're going to talk about it more. But a heart score is used to help us determine who is safe to go home in a patient that may have unstable angina or another cardiac issue that we're not able to diagnose with our troponin or EKG. So in short, the way we diagnose an InSTIMI is by troponin. The way we diagnose a STIMI is by EKG. And then everybody else that comes in with chest pain, we get a heart score. And this helps us determine who's safe to go home and who needs to come in for further workup. Because unstable angina can have a normal troponin and a normal EKG. It's really just based off of the patient's history and how their chest pain is being described by the patient. So we use their history and the heart score to help us figure out who can go home and who needs to come into the hospital. All right. Pneumothorax, we diagnose by chest x-ray. We can also use ultrasound. Pneumonia, we diagnose using chest x-ray. I'll have some examples of all this coming up here. Aortic dissection, a chest x-ray can help, and I'll show you an example of this, but the CTA of the aorta is the gold standard for diagnosing aortic dissection, at least on our workup. For pulmonary embolism, we have things like the PERT criteria, the D-dimer, and the CTA to help us diagnose that. And I have a slide dedicated to that we'll talk about all that. Esophageal rupture, also known as Boerhaav's, we diagnose using a chest x-ray, looking for free air, either in the mediastinum or free air underneath the diaphragm or both. That's what helps us diagnose an esophageal rupture. And history becomes important here because this is a patient that's been having multiple episodes of vomiting over and over and over again. And now, is having a lot of chest pain. And then pericardial tamponade, we use an ultrasound for. So on these life-threatening causes, then you can see why almost every chest pain patient that walks into the ER, no matter what's causing their chest pain, you will notice that almost everybody gets a chest x-ray and an EKG. That's just standard. And that's because look how many things you can rule out or start to rule out by just getting those two simple things, right? So you'll notice that when you're in the ER, chest x-rays and EKGs are given to everybody who's complaining of chest pain, just about. Questions on this slide?
Not a question, Dr. Kendall, but if I
Oh.
can just echo you really quick, because I know we have a lot of third years in here. This would be a really good slide to take a picture of, because you do get asked it. Like in both of my EM rotations, they were like, give me 5 differentials, why you don't think it's that, what you're going to do to rule it out. That's just like recurring all the time. So this would be a really good slide.
Yes. And I can send these slides to y'all too, so that you have them. You can send them out to everybody, and that'd be too. But yeah, please feel free to take pictures and all that kind of stuff too. It is very common. These are very common questions. All right, so here's the heart score. Are y'all able to see that? I don't know can y'all see it with the
Yeah, we can see it.
hide floating controls. There we go. Oops, sorry. So the heart score is used again to help us in our patient with chest pain who are concerned about possible ACS. This is off of MD Calc. It's very easy to find. It's very easy to use. And basically all you're doing here is you're plugging in your numbers here to kind of determine how at risk this patient is. So based off the patient's history, this is the one subjective part of the score. You kind of say, okay, after hearing this patient's history, I'm not suspicious at all for ACS. So I'm going to give them a 0. Or I'm moderately suspicious, so I'm going to give them 1 point. Or I'm very suspicious. This patient is telling me they have chest pain every time they walk, or they're telling me they had chest pain every time they walk, and now all of a sudden they're getting a chest pain even when they're just sitting down, right? So that's highly suspicious. So I'm going to give them 2 points. The EKG is, if normal, it's going to be no points, 0 points. If it's non-specific kind of issues, maybe some like flipped T waves, some leads, or maybe a couple little new changes compared to their old EKG, then we can give them a point. And then if they have significant ST deviation, either ST elevation or ST depression, then we give them +2 points. Their age determines how many points they get as well. Risk factors, notice here and here that positive family history is here. Smoking is in here. Obesity is in here. Of course, our hypertension, hyperlipidemia, and diabetes are in here. All those things we were harping about earlier. Prior MI, prior cabbage, PCI, all those type of things. All those things we were mentioning before. So what do you think your attending wants to hear? These things right here. These are they want to hear that you've asked about these risk factors. And then our initial troponin, was our initial troponin normal, 1 to 3 times the normal limit, or greater than 3 times the normal limit? If everything is, if the score adds up anywhere between 0 and 3, your risk of MACE, or major adverse coronary event, is less than 2%. And that's an acceptable risk in the emergency department to send somebody home. If your risk of MACE is less than 2%, then you can go home. Once you get above 3 points, 4 and above, the risk is too high and you admit those patients. So this is how we admit the patient who comes in. They have a kind of suspicious story, but not really convincing. Their EKG is a little funny, but nothing too crazy. You can't diagnose a STEMI off of it. Their troponin is normal, and but they have 3 or more risk factors, right? That gets us a 4 right there. And that patient, even though their workup isn't showing in STEMI and it's not showing STEMI, we still can't completely rule out the rest of ACS. So they come in for a stress test, an echo, possibly a cath, whatever you can get in the hospital. Does that make sense? Okay. The next thing is the PERC rule. The PERC rule is used for ruling out pulmonary embolism. So it says it in the name, right? Pulmonary embolism rule out criteria rule. That's kind of redundant, but this is also an MD Calc, super easy to use. This one, if you answer yes to any of these questions, the patient is what we call PERC positive, and we move on with our diagnosis, or we move on in our algorithm, and I'll show you that on the next slide. So, and somebody who you are concerned for with a pulmonary embolism, you're going to ask them, find out how old they are. Is their heart rate greater than or equal to 100? Is their room air sat less than 95? Not is it less than 90? We all get concerned about like 88, 89. It only has to be less than 95. It only has to be less than 95 at any point during their visit to the emergency department. So if they walked into the ER and their initial triage vitals said that they had a room air sat of 94%, by the time you've seen them, they've been laying in the bed resting, their room air sat's now up to 98%. That doesn't count. If you're concerned about PE, this is positive and you have to go on to the next step. Do they have unilateral leg swelling? Do they have hemoptysis? Or are they coughing up blood? Any recent surgery or trauma? Any prior history of PE or DVT? Any hormone use like oral contraceptives? If any of these is positive, they are what we call PERC positive, and their chance of PE is greater than 2%. And so you have to go on to the next step here. If there's 0, their chance of PE is less than 2%, and you should go on to something else. You've now effectively ruled out any possibility of this patient having a pulmonary embolism, and you go on to other possible diagnoses, like your other life-threatening causes of chest pain. Does that make sense? Okay. So here is my way of describing how we have a patient who we've come in and we're concerned about possible PE. So over here on the left, I have no concern about pulmonary embolism. So I don't do any of this stuff, right? I go on and I look for other causes of chest pain. I have a patient come in. Pulmonary embolism is on my differential, but my suspicion, my clinical suspicion, based off my history and my physical exam, is low. I have a very low suspicion. Because I have a low suspicion in my mind for pulmonary embolism, I move on and do the PERC rule, okay? If my PERC rule, which we just talked about, comes back negative, then I look for other causes of chest pain. If my PERC rule comes back positive, I get a D-dimer. D-dimer is a lab test that tests for the breakdown products of a clot, specifically the D-dimer. It can be a certain amount. They can have a certain amount and still be negative technically, but once it goes up above, most places use like a cutoff of 500 or 550. Once it goes above that, it's considered to be positive. If my D-dimer is negative, I've ruled out PE effectively, and I'm going to go look for other causes of life-threatening chest pain. If my D-dimer comes back positive, though, now I go and I do my CTA of the lungs, or what we call in my institution a CTPE protocol. So this is where we inject contrast into the chest at a specific time during the arterial phase, and trying to look for pulmonary emboli. Okay, and I have a picture of that coming up later. So we do that. Now, if my clinical suspicion for PE is moderate to high, I skip all of this junk and I just go straight to CTPE, because remember, even with the PERC rule, it's less than a 2% chance, but there's still a chance, right? You're telling me there's a chance. Same thing with the D-dimer. Less than 2% chance if that D-dimer is negative, but there's still technically a chance. So we don't mess with this. We don't play the chance game in the ER. If we have a moderate to high suspicion, if this patient comes in tachycardic and hypoxic and they've had a DVT recently diagnosed, I'm not doing any of the PERC or dimer thing. I'm just going straight to CTPE. Okay. Everybody good there? Okay. So our workup, therefore, on most chest pains, we typically obtain CBC and CMP. As you can tell, these are probably pretty useless. The only reason I'm getting a CBC is usually to check for anemia, just to make sure that maybe they're not having like cardiac ischemia because their hemoglobin is 4, right? The only reason I'm getting a CMP is I'm looking for things like electrolyte abnormalities. Maybe they're having chest cramps because their calcium is super low. And I'm also looking for things like AKI, acute kidney injury, just to see if there's something else going on here that could be possibly leading some chest pain. Of course, troponin, EKG, and chest X-ray, which I've harped on enough. So that's the typical chest pain workup in the emergency department. So then treatments, right? This is another thing that medical students often forget. They come out and they're like, oh man, Dr. Kendall, I have this patient with chest pain. I know exactly what it is. I did this awesome history. I took this amazing physical exam. I went through all my differentials in my head and I know immediately what this is and exactly the kind of workup that I want to do. Meanwhile, the patient's in the bed writhing in 10 out of 10 pain, right? Because we have forgotten to treat the patient. We are so wrapped up in our workup for them that we forget to say, hey, we need to take care of this patient in front of them and get them to feel better, right? So don't forget about pain control. Don't forget about interventions like aspirin, which is the only thing that has been shown to reduce morbidity and mortality in acute coronary syndrome, right? If they're vomiting a lot, don't forget to give them things like IV fluids and nausea control, like IV Zofran. So when you're going to your attending and you're telling them, okay, this is my differential, and then this is the workup that I want to do, continue on and say, and I'd also like to treat my patient's symptoms with blah, 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 right? So don't forget about the treatment aspect of your plan. All right, so for our patient, the results are starting to come back. So we got a CBC on our chest pain patient, completely normal. We got a CMP on our patient, completely normal, okay? Now we get an EKG. Can everybody see the whole EKG?
Yes.
Good. All right, so who wants to, is there anybody who wants to volunteer to read this EKG? Hint, it's not going to get any easier. This is your easiest one.
I mean, I guess I can give it a go.
Yeah, give it a shot.
So just at first glance, I can kind of already tell it's sinus Brady. I know it's sinus because I see waves. So then I immediately just look at V1, V2, V3. I think there's left ventricular hypertrophy because of the tall R waves that you can kind of stack with V5 and V6. It's normal access because 1 and AVF are both positive. I don't see any like overt ST elevations and nor flip T waves or any ST depressions.
Okay.
And it looks regular to me. The RRs are pretty regular.
Very good. So overall, what's your final diagnosis on this EKG? Normal, somewhat abnormal, completely abnormal,
I would just say at the moment, normal.
Normal.
I mean, sinus pretty, but normal.
Okay, yeah. So yeah, overall, great job. I think you hit on most of the points of what I'm trying to convey here with this EKG. This is a normal sinus rhythm EKG. There are no signs of ischemia on this EKG. There's no arrhythmia or anything like that. I'd have you write this down because EKGs can get very complicated. It's very few times that you have this perfect EKG that looks completely normal, right? So the first thing that I want you to do is diagnose a rate, right? So always do rate first, and we do that by looking at the rhythm strip. There's a couple of ways of doing this. I think the easiest way is counting up all of the QRS complexes in this rhythm strip. So we count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. We then take that number and multiply it by 6, giving us a rate of 72 beats a minute. So not, almost down to bradycardic, but not quite. I would still call it a normal rate. It falls within 60 and 100. There's another way too that takes a little bit more memorization, but you find a QRS on a dark line. If the next QRS was here, the rate would be 300. If the next QRS was here, the rate would be 150. If the next QRS was here, the rate would be 100. If the next, oh, I lost my cursor. If the next QRS was here, the rate would be 75. The next QRS was here, it'd be 60, and so on and so forth. And it just takes a little bit of memorization. But I like the counting method and just multiply it by 6. So our rate is 72. Our next one is rhythm, right? So we look to see if it's a sinus rhythm or not. So we look to see on our rhythm strip, do we have a P wave before every QRS? And do we have a QRS after every P, right? So P wave, QRS, P wave, QRS, P wave, QRS, QRS, P, QRS, P, QRS, P, and then all the P waves look the same morphology for the most part, right? So now, just off of our rhythm strip, we can say this is a normal sinus rhythm, right? Because it's sinus because of P waves and QRSs. It's normal because it falls between 60 and 100 beats a minute. The next thing is axis. So we've done rate, rhythm, axis. I'm not going to spend a whole lot of time on here, but I like 1 and AVF to look at those. And this is a normal axis. Axis is the least important thing when you're talking about an EKG. It does not help us at all in the emergency department for the most part. So rate, rhythm, axis. Then we talk about intervals. Again, this becomes important when we're talking about arrhythmias. Again, I come down here to our rhythm strip, and I'm looking to see, do I have a normal PR interval, which should be 200 milliseconds or less? Do I have a normal QRS, which should be 120 milliseconds or less? And does my QT look appropriate, right? And QT is the one where I'll usually cheat. I don't typically try to calculate out a QT. I'll just look up at the EKG and just make sure that that's spitting out correct looking numbers there. So rate, rhythm, axis, intervals. Now I finally get to look at what I really wanted to look at the EKG for, and that's the ST changes, right? So ST elevations, depressions, and T wave inversions, right? The biggest thing I want to harp on here is that you have to look at this in contiguous leads, because remember the definition of a STEMI in most leads is greater than 1 millimeter of ST elevation in 2 contiguous leads. But that does not mean that like, oh, well, AVR and V1 are together. They're next to each other in the EKG. So that must make them contiguous. Nope, it does not. The contiguous leads are 1 and AVL. These are looking at the lateral aspect of the heart. 2, 3, and AVF. These look at the inferior aspect of the heart. V1, V2, V3, and V4, depending on where they're placed on the chest, you can call them septal and anterior. Most people just call them anterior septal leads. And then we get to V5 and V6, and we're back to the lateral aspect of the heart. Okay, so that's how you want to look at this. When you're looking for ST elevations, depressions, and T wave inversions, you say, okay, I'm going to look at 1 in AVL. Okay, none of those are in either of these leads. Okay, I'm going to look at 2, 3 in AVF. None of those things are in any of these leads either, right? V1 and V2, nope. V3 and V4, nope, everything's good. V5, V6, nope, good. Okay, So now I know that this is a normal sinus rhythm EKG with no ST changes. So it's a normal EKG. Everybody good there? Okay. So then the next one, can we all see the abnormality here? Right off the bat?
Yes.
Right. So again, a lot of times it's not always this obvious. But I put this EKG up here because I want you to not look here. I want you on every single EKG to start with your rate, rhythm, axis, intervals, every single one. Because eventually what will happen is if you get out of that pattern, you'll get handed an EKG that looks funny. And then all you're going to do is focus here, and you're going to miss that this patient is in a complete heart block, right? Which this one isn't, but you have that potential, right? Because you could easily miss other things because you're now focused on this. So you got to do the exact same thing every single time with every EKG that you will ever be handed in your career. Which if you go into emergency medicine, it's going to be in the thousands, right? I see at least 20 to 30 of these a day, a shift, right? And so you have to become very, very focused and disciplined about, okay, I'm going to start with my rhythm strip, and I'm going to look at my rate and my rhythm. Then I'm going to look at my axis. Then I'm going to look at my intervals. And now I finally get to look and say, okay, there is ST elevation in 1 and AVL. There's no elevation in 2, maybe a little bit of depression in 3, nothing in AVF. I have definite ST elevation in V1, V2, V3, V4, all of those. And I also have elevation in V5. So this is definitely a STEMI, right? It's probably going to end up being the LAD, which is that also known as the widowmaker. This is kind of a typical LAD lesion EKG here. All right. So if this patient was having this, we'd know the diagnosis immediately, right? What's the diagnosis?
STEMI.
STEMI, right? You're done. You have solved the problem. You know exactly what this patient has. And now okay, we've got to get cardiology on board, and we've got to give them aspirin, and we probably need to give them heparin and whatever else, right? All right. Let's talk about chest x-rays real quick. Katie, are we okay if we go over a little bit?
Yeah, that's fine.
Okay. If anybody needs to leave, I totally understand. I know Katie's recording this. So if you need to hop off, please do. We're going to go, the next couple of things here, slides are going to be chest x-rays and kind of going over abnormal ones. To save time, I'll just kind of go through, and spoiler alert, I want you to do the exact same thing with chest x-rays that you do with EKGs. So I want you to find your pattern of how you're going to read a chest x-ray. And I want you to read every single chest x-ray from here on the same exact way. And that way you don't miss things, right? The way I like to read chest x-rays is the ABCDE method. A stands for airway. So I start off looking at the airway, which is the trachea. I'm looking to make sure that the trachea is midline. So I want to see these little spinous processes from the thoracic vertebrae and some of the cervical vertebrae. I want to see them line up in the middle of the trachea. That tells me that this is midline. It's a little bit off here. That's okay. Just pretend like it is in the midline, right? I follow that airway down to where I can see the carina. Can everybody kind of see this here? And then that gives me my left mainstem bronchus and my right mainstem bronchus, right? I want to see both of those, and I'm going to see that they're both pointed in a downward direction. I want to make sure that I don't have any foreign bodies in the trachea. Maybe there's a kid who swallowed a coin, or this patient's intubated. I want to make sure that my ET tube is appropriately positioned above the carina. So that's what I'm looking at when I'm looking at airway. B is bones. So I'm now looking at all the bony structures. I'm looking at the ribs, right? So the posterior aspect of my first rib coming around to the anterior aspect of my first rib. Here is my second rib, the posterior aspect of my second rib coming around to the anterior aspect of it. Oops, sorry. Third rib, fourth rib, so on and so forth, right? I'm looking to see if there's any deformities or concavity to the chest or anything like that that might make me think that there's a rib fracture there. The bones also consist of the clavicles. So I'm looking at the clavicles, making sure that I don't have a broken clavicle. Also the scapula, right? Looking at the scapula. Every once in a while, you'll see a humeral head poke in here. I want to see that too. And then I want to look at the spine and come all the way down. So any bony structure that's in this x-ray, I want to evaluate it and just make sure that it looks normal. C stands for cardiac, or our cardiac silhouette. The biggest thing that I want you to remember here is the aortic knob. That's this thing right here. If you can imagine, this is where the ascending aorta is coming up, coming over into the aortic arch, and then twisting down into the descending aorta. So what you're seeing here is part of that aortic arch. That's the aortic knob. And then after that, then we have the rest of our cardiac silhouette. You want to make sure that you can see the left and right side of that silhouette come all the way down to the diaphragm. Same thing here. We can see that cardiac silhouette coming all the way down. If I can't see that cardiac silhouette, or if I can't see a defined aortic knob, that tells me that something is wrong and I need to pay attention to that. And we'll talk about what those things could be here in a second. So that's C, cardiac. D is diaphragm. So I'm looking at the contour of my diaphragm here. I want to see good sharp costophrenic angles here. You can see how nice and sharp those are. If I can't see a costophrenic angle, then that means that there's something there, some sort of fluid, either just normal, like a pleural effusion, or it could be a hemothorax or something like that. But if I can't see that sharp costophrenic angle, that means that there's fluid there. Same thing here. And then I'm also here looking for free air. I'm looking for air underneath the diaphragm as well, trying to make sure that this patient doesn't have a perfed viscus, specifically in chest pain and esophageal rupture. E is everything else. So now I finally get to look at the lungs. Now I'm looking at the lungs to make sure that I don't see any consolidations. I'm looking to make sure that I can see lung markings going all the way out to the outer aspects of that chest wall. If I don't see lung markings all the way out, that would make me think that there's a pneumothorax. I'm looking for any kind of other, abscesses or anything else. But now I finally get to evaluate the lungs. And again, the reason for this is because as soon as I put this chest x-ray up there, I guarantee you every one of your eyes went to the lungs. Nobody else looked at anything else. And so this is a way to make your mind see the entire x-ray and make sure that you're not missing something else that could be blatantly obvious, but it's covered up by the fact that you're staring at the lungs. So speaking of which, does anyone want to give a crack at this chest x-ray here? So would everybody agree that my airway is good? Airway is midline, right?
Yes.
Okay, good. B, bones. Everybody agree that my bones look good. My contours are normal. Everything looks good here. My spine is normal. Ribs all look good. Yes, no fractures or anything like that.
Yes.
Yes.
D, cardiac silhouette. We can see an aortic knob, yes?
Yes.
Yes.
Okay. Can we see the cardiac silhouette clearly defined all the way down to the diaphragm?
Yes.
Yes.
What about right here? Do you see how it's a little bit kind of obscured almost? It's more obvious on this side. Can you see a clear cardiac silhouette all the way down?
No.
No, you cannot, right? So that tells me something is here. What it is, I'm not entirely sure yet, but I know that this is now an abnormal chest x-ray. D, diaphragm. Can we see a costophrenic angle here?
Yes.
Yes, we can. What about on this side?
Yes.
Yes.
Good. Do we see any free air under the diaphragm?
No.
No. Okay, good. So we know that there's not an effusion. We know it's not just free fluid floating around in the lung, whatever this is that was abnormal here. Okay. And then E, everything else. Now we finally get to look at the lungs. Can we all agree that for the most part, the left lung is fairly normal? Maybe a little bit of schmutzy stuff here, right? But let's call this normal for now, right?
Yeah.
What
Mhm.
about this lung, especially when we compare this side to this side? What is this?
Consolidation.
Consolidation.
Yeah.
Consolidation, which would mean the diagnosis is what?
Pneumonia.
Pneumonia.
Pneumonia. Very good. We know it's not an effusion, remember, because it's not gravity dependent. So this is inside the lung. This is a consolidation inside the lung. This patient has pneumonia. What about this one? Can we all agree that the airway is midline?
Yes.
Looks good, right? Can we all agree that the bones look good?
Mm-hmm.
Normal
Yeah.
contour, everything else is good there. And we all agree that the cardiac silhouette looks pretty good. We have a good aortic knob. We can see that cardiac silhouette going all the way down to the diaphragm. Yes?
Yes.
Yes.
Good. Diaphragm, can we see good costophrenic angles?
Yes.
Yes.
What about here?
It looks-
Looks blunted.
Yeah, very good. It's blunted, right? See how nice and sharp this one is? This one is not. So now we know something abnormal is going on here, right? We've got a blunted costophrenic angle. What this is, blood or just fluid, I don't know. But it's definitely some sort of fluid within the chest cavity. All right, now we finally get to look at the lungs and everything else. Can we all agree that one of these lungs is abnormal?
Yes.
Yes.
Which one is abnormal?
The left.
The left
The
one.
left one. What's going on with it?
It's collapsed.
Air.
Good, air, right? So that's called what? What's the term?
Pneumothorax.
Pneumothorax. And what's the treatment for a pneumothorax?
Needle
Just do.
decompression.
Needle decompression, chest tube, finger thoracostomy, all acceptable answers. So yeah, this patient needs a decompression of the chest in some form or manner. This fluid maybe they have a broken rib somewhere, who knows what it is, but this is what a pneumothorax looks like on a chest x-ray. You can see, look at those lung markings, how they come all the way out. Do you notice how there are no lung markings here, right? That's
Mhm.
what we're talking about, lung markings. Look at this is a great example of what we're talking about, lung markings versus no lung markings. All right. What is going on here? But see, this is why we look at chest x-rays the same exact way every single time, right? So let's start, because I just look at this like, oh my gosh, what is going on here? All right, let's try to find an airway. Do we see an airway anywhere?
I mean, not one that's
Okay.
like clear.
Not that's clear. I agree. We don't see a clear airway. At least I don't anywhere. Okay, let's move on. So the airway is abnormal. We know this chest x-ray is definitely an abnormal chest x-ray now. B, bones. Do we see any abnormalities with our bones? Maybe a little bit of weird kind of contouring here. You can see how we've kind of lost that convexity here. It almost becomes a little concave right there. You see that? So I would almost expect like maybe a rib fracture or something, although I don't see one. So not completely normal, but we'll just say for right now, not really sure, but we'll have to continue to look. The other thing I noticed here is I don't see any clavicles on this patient. Do you see any clavicles? Kind of weird. Anybody watch Stranger Things?
Yeah.
Yeah.
Is it possible for somebody to not have clavicles?
Isn't it like Dustin who doesn't have them? or
Yeah.
something?
Yeah. Yeah. Do you know the name for that disease?
No.
It's like it's clino something something. I always have to look it up, but it's not something we have to diagnose in the emergency department. But I always look for clavicles because some people just don't have them, which is kind of interesting. All right, C, cardiac silhouette. Do we see an aortic knob?
No.
No.
No. Do we see the cardiac silhouette coming all the way down to the diaphragm?
Somewhat.
Yeah, I'd say we do, right?
Mhm.
We see that cardiac silhouette coming all the way down. So now this is weird, right? Because we can't see an airway and we can't see an aortic knob. Both of those structures are located in what central structure inside the chest?
Mediastinum.
The mediastinum. Very good, right? So maybe there's something going on with the mediastinum. All right. D, diaphragm. Do we see a good diaphragm contour here? Or is this the
You
diaphragm
see,
here? Where's the
that's
diaphragm?
the
Is this it? Or is
diaphragm.
this it?
Yeah.
The bottom one.
That's the diaphragm? What if I told you this
I
is
would
the
say
diaphragm?
that's the diaphragm right there. It looks
So
kind of
what's going on?
elevated. Yeah.
That air under.
Yeah,
Air.
this is free air under the diaphragm. This is your liver edge. And then here's free air under the diaphragm. What about this side of the diaphragm? What's going on there?
It looks like it's being collapsed.
Yeah, this is what we call a deep sulcus sign. Deep sulcus sign is pathognomonic for pneumothorax. Okay, so if you ever see a deep sulcus sign, that means that there's a pneumothorax here. What if I told you, now we get to go to E, everything else. So we're not seeing great lung markings on this side. Maybe we're seeing some lung markings here. I don't see any consolidations. I see amazingly a good costophrenic angle here, right? I can't see a costophrenic angle here because it's so far down, right? But for lungs, it's definitely some abnormalities there too. So then the history becomes important here. What if I told you this patient had been vomiting for 2 days straight?
Esophageal rupture.
Esophageal rupture. Exactly. So what this patient has done is they've ruptured their esophagus, which has now led to free air underneath the diaphragm. It has led to free air inside the mediastinum. So this is now what we call pneumomediastinum, which is now obscuring kind of all of our structures within that mediastinum. And you see all these striations here. That's not in the lung. This is the patient's his pectoral muscle with air in it. So his air has been has traveled up through the mediastinum now into his soft tissues and down into his muscles. So he's got pneumomediastinum, he's got pneumoperitoneum, he's got a pneumothorax, and now he's got air and all in his subcutaneous tissues and muscles and all that kind of stuff. This guy has air everywhere, right? So he's in bad shape. He or she, I'm sorry, I shouldn't discriminate. They're in bad shape. All right. Any questions on that? Do you see though how we took this complicated looking chest x-ray and just broke it down into its most simple forms and then came up with an actual diagnosis for what this was?
Dr. Kendall, I have a question regarding the deep sulcus sign. You'll only see this on like when they're like laying in the bed, right? Like when it's like like a portable chest x-ray, like you won't see that standing up, right?
No, if it's big enough, so the deep sulcus sign, you can see standing or sitting or laying, it doesn't matter. I think where I've definitely seen pneumothoraces missed is when it's a smaller pneumothorax and the patient is laying flat on their back on the bed. The air will come to the front, kind of rise to the front, and so the lung itself will look normal in a chest x-ray, which is why you can see on this one it's erect, right? So this patient is at least sitting up, because then that way the air comes up here and you can see the pneumothorax up on top of the lung there. So whenever you're concerned about a pneumothorax, you always want to make sure that the patient is in some sort of at least a seated position so that the air is moving up and you can see it and diagnose it on a chest x-ray. Does that make sense?
Yes, sir. Thank you.
All right. I'm sorry for the poor quality on this one. This comes off of my iPhone. This is a patient that I had in residency. Okay, so airway. We're expecting the airway to be here, right? Here's our spine. Is the airway there?
No,
No. Where's the airway?
right there.
Yeah, so it's shifted way over, right? Way over to the right here. There's our airway. We're going to follow it down. What's this right here?
It looks like, yeah.
What is it?
Is it the left main stem?
Yeah, that's your left main stem bronchus or left main bronchus here. Here's our right bronchus pointing kind of in a weird direction too. So my left main bronchus is elevated. It's pointing up instead of down, which is strange, right? So right off the bat, we know this is going to be an abnormal chest x-ray. B, bones, for sake of argument, let's just say all the bones are normal. We have the clavicles, chest is normal, everything else is normal, okay? C, cardiac silhouette. Do you see an aortic knob here?
I
No.
know.
No.
Is it
What if I told you this was the aortic knob?
I would believe you.
So, and then do we see the rest of the cardiac silhouette going all the way down to the diaphragm on this side?
No.
No, what about on this side?
Yes.
Yeah, we see it on this side. So again, we know there's something abnormal here, whether it's fluid or a consolidation, something is keeping us from seeing the cardiac silhouette going all the way down. And then our mediastinum is significantly widened, right? That aortic knob is gigantic, right? So this is still continuing to be abnormal. So that's cardiac silhouette. D, diaphragm. Can we see the diaphragm here?
Yes.
Yeah. Do
Yeah,
we see a good clustrophrenic angle here?
yeah,
Yeah, we do. Do we see any air under the diaphragm?
no,
Nope. What about on this side? Can we see a diaphragm here?
No.
Nope. Can we see a clustrophrenic angle?
no.
No. So we know that this is what then?
Fusion.
A fusion, right? It's some sort of an effusion because that clustrophrenic angle is blunted. Could it potentially be a consolidation? Maybe. There's could be some consolidation there as well, but there's definitely something that's gravity dependent in there, some sort of free fluid. All right, then we get to go to E, everything else. And I'll tell you right now, there's no pneumothorax. I know it kind of looks that way, but there are lung markings all the way out to the periphery in both lungs. So our lungs are otherwise okay, except for this thing down here, which we've already kind of talked about in both cardiac silhouette, cardiac portion and the diaphragm portion. Any guesses on what this is?
Hemothorax.
Okay, this could potentially be a hemothorax, but that doesn't explain the large mediastinum, the shifted trachea, the elevated left mainstem bronchus. None of that is explained by a
I was,
hemothorax.
I was gonna say like some type of dissection.
Good, yeah. So this is an aortic dissection. So you can have a completely normal chest X-ray and aortic dissection. You cannot technically diagnose it, but this is the classic appearance of an aortic dissection when you do have findings on a chest X-ray. So shifted trachea, deviated trachea with an elevated left mainstem bronchus, a widened mediastinum, and then a large left effusion, usually blood, so likely a hemothorax here. But those are our kind of classic findings of an aortic dissection. So that's what that looks like. But again, you can see how complicated this was to us initially, but we just went through it step by step and we were able to come to our diagnosis. Okay. Any question or any thoughts on what this is?
Is this a PE?
Yeah, this is a PE.
Saddle,
It's hard. Yes. Yeah. So this is a saddle embolus or pulmonary embolism that's straddling that break here of the pulmonary artery where it bifurcates. So this is what a pulmonary embolism looks like on CT. I wish we could go through actual images and show you because it's really fun to kind of follow these down. But this is the contrast within that pulmonary artery. And then you'll have these what we call filling defects where that contrast won't light up because it's filled with clot instead of blood. Okay, so that's what a PE, this is how you diagnose a PE. Remember, low risk PE patients, we start off with our Perk rule, then dimer, then CT, and moderate to high risk patients, we just go straight to CT. All right, so the final results on our patient, our CBC and CMP were normal, our troponin is 1,000, our EKG was normal, our chest X-ray is normal. What is our final diagnosis?
And STEMI.
Yeah, very good. And STEMI, right? So the troponin is up, but we have a normal EKG. That tells us that it's an NSTEMI. So the treatment here is aspirin, heparin, cardiology consult for an urgent cardiac catheterization. In summary, you will encounter a patient with chest pain on every single shift. Remember those 7 life-threatening differential diagnoses. You will be asked about them and you are expected to be thinking about them at all times in patients with chest pain. Use your history and physical exam to narrow your differentials and your workup. Clinical decision tools such as the heart score and the PERC score can help us with our appropriate disposition. Practice makes perfect with EKGs and chest X-rays. So anytime you're on shift, when that attending is looking at the EKG, ask them, can I see that EKG after you? Open up every single one of your chest X-ray images and look at every single chest X-ray image that you can and practice that ABCDE method. And then always trust your instincts and don't just rely on labs and imaging. If the patient looks funny to you or the history just sounds funny to you and all their stuff is completely normal, trust your instincts and either do more of a workup or get them admitted so that more workup can be done. That's all I got.
Awesome. That was a really awesome talk, Dr. Kendall. Thank you so much for coming tonight and giving us that.
Yeah, of course. I'm sorry it took a little bit longer. I'm used to giving this in person. So, but yeah, it was a lot of fun, and I hope everybody was able to learn something. I am going to put my email address in the chat. So if you have any other questions, or if something didn't make sense, please feel free to reach out to me. I'm more than happy to go over it further.
Awesome. Does anybody have any questions before we go? Awesome. Well, thank you again, Dr. Kendall, and thank you for everyone who came out tonight. And if you haven't signed in, one last thing, please sign in on the sign-in sheet. And if not, we hope you guys have a great night.
Good night, guys.
Good
Thank
night.
you very much.
Thank you.
Good night.
Thank y'all.